While we are getting the lights down, one thing I thought I should mention to any of those of you who are not very used to doing pediatric angiography is that the femoral artery in a term baby, so a full-term baby, the common femoral artery actually measures 2 millimeters in diameter if you look with ultrasound. If you put in a 4 French vascular introducer sheath into a common femoral artery, given the fact that you always get a little bit of spasm, you'll actually fill that lumen with the 4 French sheath, because the 4 French sheath actually accommodates a 4 French catheter, so the outer diameter actually of a 4 French sheath is near a 5. We have actually put in 4 French introducer sheaths into the brachial arteries of premature babies who are only weighing about 2.7 kilograms in weight, and when you actually do that, you close the arterial circulation down dramatically in an arm. That arm, during the time you've got the sheath in, will remain cold, pulseless. It'll look somewhat mottled, slightly blue, and it's always disconcerting actually at the time you're doing it. But I have actually done it in small premature babies, and we've left these vascular introducer sheaths in for up to about 4.5 hours during some difficult embolizations, and the arm recovers well, the artery recovers well. You have to be very gentle and do it correctly with image guidance. But you can actually preserve the parent artery that you've accessed, even in premature babies. We liberally use heparin and vasodilators, and actually we put on nitroglycerine patches actually over the access sites as well. So you can do it, just you need to take time and sit down while you're doing it, because the vessels are small and always use image guidance. So I'll quickly get on to the talk. I've actually hoped that this talk will be significantly shorter than the others. And like Niagara Falls, and here are 2 photographs of Niagara Falls, which is about an 1.5-hour drive outside Toronto, which can actually be very, very dramatic. We always think of high-flow vascular anomalies as being very dramatic as well. And I'm using the word anomalies to encompass all the groups, the vascular tumours and the vascular malformations, which exhibit high flow. I'm not just going to talk about arteriovenous malformations, because in pediatric practice we do see children with high-flow vascular tumours that are shunting that require interventional treatment. And so back to this classification, and I keep going back to this classification. So within this, the vascular tumour group, you can get significant shunts leading even to cardiac failure in infantile hemangiomas. You can get intratumoral arteriovenous shunts in the congenital hemangiomas, mainly the Riches, not the niches, and also in the vascular malformation group. Obviously we're talking about arteriovenous malformations, fistulas, and actually I'll show you now, but in the next lecture, in the complex combined vascular malformations, you actually get multiple arteriovenous fistulae and high flow in Parkes-Weber syndrome. So it's important to stage the peripheral arteriovenous malformations, and I would say at the outset, I think in pediatric practice, we cannot cure peripheral arteriovenous malformations ever, whether we use interventional embolization techniques, whether there's surgery, whether there's combinations. We can provide control of these lesions. These are the most difficult lesions, I think, that we sometimes see in pediatric medicine. And it's important to understand the scoring system for arteriovenous malformations. And the scoring system that's conventionally used is something called the Schobinger severity scoring system. There are 4 stages of arteriovenous malformations. And this is what we're going to talk about to start with. Stage 1 is when the malformation is quiescent, so it actually mimics a capillary malformation. Actually, if you put the Doppler ultrasound on this, like a capillary malformation, you will see high flow beneath the surface of the skin in this. So this is not a capillary malformation. This is maybe described as a pseudo-capillary malformation because of it, purely from a descriptive standpoint. But this is stage 1. It's quiescent. Stage 2 is when you actually get expansion of the lesion. This is actually the pinna of a girl, and inside there's actually some tissue expansion of the lesion. Sorry, there's expansion of the lesion just inside the pinna here. This is stage 2, when the lesion becomes warmer, there are bruits, there are thrills. This is a clinical severity scoring system. It's a clinical assessment. And then stage 3 is when you actually get destruction as a result of the AVM because of steel phenomenon. You get ulceration, as in the pinna of this is a different girl to here. You can get hemorrhaging from the skin, bone lysis, and the onset of pain. Usually when you get pain in peripheral AVMs in children, it's fairly unremitting, although it does wax and wane. Usually this stage in children we don't see until they're actually past puberty, and so they're in their early teens. But they don't necessarily progress to this stage at that age. It may take longer. And then finally stage 4 is when you've got clinical cardiac failure. These lesions here, these are small lesions, these are not really going to give rise to cardiac failure. But this system is useful in when we decide, are we going to treat? So which arterial, and I'm not talking about intracranial arteriovenous malformations. I think actually these are a different entity. But with regards to peripheral arteriovenous malformations in children, which ones are we going to treat? Well, stage 1 we don't, in our practice, and I think probably in most of North America, that includes USA and Canada, we wouldn't treat stage 1. When we get to stage 3, certainly when we get to stage 3, and without any question stage 4, we have to treat. You can see the progression in this girl. I showed you this I think before, from 12 to 16 years of age, where there's enlargement to the little finger and middle finger. She's getting much more pain now in this little finger than ever before. There's no question we'd start treatment. In the USA, they'd start at stage 2. And there are various reasons, not just clinical reasons, that they might start treating at stage 2. But some people say when the dog's out of the kennel, you start treating, you'll never get the dog back in the kennel, so maybe stage 2 might be a good idea. But the problem is that these children require many repeated treatments. There are high risk. This is the highest risk population for treatments of vascular anomalies. 20% will have complications. It's reported that maybe up to 10% can even get paralysis, or well, certainly nerve injuries from embolization treatments. So we've really got to know what we're dealing with and when to start. So in practice, we don't usually treat at stage 2, which may explain, although we see many children who are in stage 2, and sometimes when we think they're really, we've seen them for a while, maybe for 2 or 3 or 4 years or 5 years going through stage 2. When we see that they're really progressing through stage 2, we'll start some treatment. So you can do a simple treatment. If it's in an extremity and involving a lot of the extremity, you can give a compression garment. Sometimes people think that this may halt the progression. I am not sure, but it certainly can help some of the problems, and we do recommend compression garments if we can. We would selectively devascularize by embolization. There's no point in doing a proximal embolization. That is the equivalent of doing a proximal ligation surgically, which will make the situation worse. So when some people ask, do you think you might make the AVM worse by doing the embolization? I think the answer simply is, if you do the incorrect embolization, you'll make the situation worse. If you actually selectively devascularize the nidus or the nidi, because there may be multiple ones in an extremity, then your chance of achieving some result will be much better. And also, the reason for selectively trying to treat the nidus is that if you do unselective treatments, particularly transcatheter-wise, then you actually risk depositing the embolic agent into arteries that are supplying normal tissue, like nervous tissue, so the chance of nerve injury is significantly higher. And then, not to forget that these children require multiple treatments. One thing I didn't say actually with the low flow treatments for the venous and lymphatic is that we actually bring our patients back every 6 weeks, and we usually do 3 treatments every 6 weeks and then reassess them 3 months later. Again, for arteriovenous malformations, we sometimes do them every 6 weeks and do 3 treatments to start with and then reassess, or sometimes we space it out a little longer, maybe every 2 to 3 months, depending on the arteriovenous malformation. We have had a patient who was in cardiac failure, actually with Parkes-Weber syndrome, and we would recommend much more frequent embolizations, and in fact we were doing them weekly, because of the clinical condition of the patient.